we move to the next speaker, Professor Steffen Weber-Carstens from the Charité University Hospital of Berlin. Professor, the screen is yours.
Yeah, thank you very much, dear Chairman, for the nice invitation, and it will be a pleasure for me to give you the talk about improving rehabilitation. Well, I do not have any conflict of interests. Before we start in looking on mobilization in ECMO patients, I just want to record the situation we do have. We all do know the situation of post-intensive care syndrome called PICS. And besides mental impairment, physical disabilities are really, really an important thing that we do know and that that are connected to this newly defined syndrome, post-intensive care syndrome. And again, if you look into pathophysiology, what is happening to the patient, to the muscle of the patient to function en masse? Well, we have, as you can see here on the left side, extensive muscle wasting, loss of muscle mass, and I will show you that this will start very, very early during critical illness. And then we have clinical entities like critical illness, myopathy, polyneuropathy, which are also linked to a decreased maximum muscle force and a decreased muscle tension. Both entities are leading to the clinical picture of ICU-acquired weakness. What is really, really important to mention and to know, ICU-acquired weakness is not a matter of long-term critical illness. It's just the beginning, and the pathophysiology is starting within the first days of critical illness. As you can see here on the left side, for the nerves, this is in healthy patients. This is a skin biopsy, and you see the small fiber nerves here in the skin. Only a few days after onset of critical illness, these nerves degenerate. And this is from my own working group, electron microscopic picture. Well, you see here still the maintained molecular structure of the muscle, but here you see that within a few days we have complete destruction of the normal morphology of the muscle in this situation, and we have a negative nitrogen balance. So what happens very early during critical illness does have a really long-term impact. And if we are talking about ECMO, and if you look at it, it's very well investigated for RDS patients. We really do know that RDS patients, even younger patients without pre-existing strong comorbidities, they have an extensive loss of muscle mass, and a real high percentage of these patients, even 5 years after discharge from ICU, they only can walk 75% of the predicted distance walking for when compared to a healthy controls. So remember, what happens within the first hours, within the first days of critical illness does have a really long-term impact. And it really does have, the question would be, how can we improve rehabilitation? How can we prevent the development of this issue? So to think about that, I first want to recover or just again bring into mind the main risk factors for the development of ICU-acquired weakness. As we could show, sepsis or systemic inflammation is one of the major risk factors, and we have done some extensive work in the molecular mechanisms that are involved. And for example, serum amyloid A1, which is a unspecific inflammatory response marker, it's covered to the microlemma here in healthy patients, where you don't see it you don't see it in healthy patients, but it's covering the microsarcolemma in critical ill patients. And we do know that also protein degradation is is started very early during critical illness, and it's linked to systemic inflammation. So keep in mind, this is one of the major risk factors.